get the context. Give me 1 second and I'll put up my slides. But yeah, so please interrupt. Let's make this interactive as we go along, as you see fit, and we'll hopefully have a good conversation. So thank you for the introduction, Sonali. I won't, let me just switch my displays. Let me, I mean, the only other thing to say, so I'll take a global angle in on this. I spend quite a lot of my time in 1 or 2 markets, but I'll try and make, but I also I represent our healthcare system work globally for BCG, and we work in, I think we've got 100 offices in over 60 countries. So I will bring in some of that. And I also manage our relationship with the World Economic Forum around the digital health transformation topic as well for the last couple of years. So that's also been a very helpful way for me to get a good overview. So I'll try and bring in some international lens, which will hopefully make it more interesting for you. What I'll cover are 4 areas today. I'll just have a look at this, where we are, the state of global healthcare and some of the challenges we're facing today. What could be a vision for tomorrow? And I'll just take from 3 markets in particular to highlight what could be coming. 6 shifts that we need to drive that change to get to the vision. And then what it means from here, and maybe some learnings across industry as well that could maybe inform how we think about how to get there. So let me start on the first topic on the state of global healthcare innovation today. So I think where we're starting from is on the left-hand side here. When you think about it, I think we've got these divergent sparks of light. And I think everyone on this call are passionate about where digital AI can really make a difference. And we're seeing lots of bright sparks in different places that are really, really interesting. The issue is that we're not necessarily connected up yet, and we're not getting a sort of system approach to it. So they are ending up as sparks, but not what we need to get is some converging light on the right that shines a way forward as well. And I think that's partly what I want to bring through from the talk today on a way to get there. So when we look across the world and healthcare, we know the challenge. There's a supply-demand mismatch. Yeah? We've got rising demand in all nations, actually, due to aging populations, chronic disease burden, constrained funding, with rising geopolitical uncertainty, and we can see that mismatch is now leading to stagnant health outcomes and decreasing patient satisfaction. Whereas we know the opportunity, and I think one of the big unlocks will be digital transformation across society, which can have massive implications for health. But to do that, we're going to need collaboration of the ecosystem as a key enabler. And then this can lead to increased access for health through safe and trusted AI solutions. So just to go into that in a little bit more detail, if you actually look at healthcare costs in high-income countries versus outcomes over the last 25 years, life expectancy in years versus health expenditure per capita, you can see that it's plateauing life expectancy, whereas health expenditure continues to increase, no matter which market you choose. And if you look at low-income countries, they're a little further down the curve, but they're also starting to bend. The curve is bending like this as well for them. And then on the demand side, if you look at aging populations, that the group of over 65-year-olds are growing faster than the overall population in most countries, definitely for the US, UK, Canada. There's 1 or 2 that's not true, but in general, that's what's happening for the majority. And when you look at that proportion over 65 years of age with multiple diseases in OECD countries, that is also going up. And you can see sort of from 2015 to 2035 there, significant increases, particularly in 3 and 4 multi-morbidity individuals. That's leading to stagnation of outcomes. So although have had life expectancy gains over the last 20 years, though it's plateauing, as I've shown you, the healthy life expectancy gains has not kept track with that. So we're living longer, but we're living with disease. And when you look across, and I just chose life expectancy gap, but you could pick a number of areas, and maternal mortality is 10x variation across OECD countries even. But there's a huge gap. And a lot of those things are due to things that are not directly within healthcare as well, that we're not addressing properly at the moment. So you've got to think about socioeconomic factors too. And then when you look around the world at that those years spent in ill health, I thought it was interesting that, US and Canada, similar, is over a year extra spent in ill health than even 20 years ago. It was the same in China and India too. So this is a global issue, a global disease issue, things to solve as well. And then finally, we look at our workforce engagement. It's dropped. My example in the UK, 23 in our recent survey globally, 23% of doctors are considering leaving the profession. Australia, 25% of doctors, only 25% of doctors felt respected by hospital management. A third of nurses globally reporting emotional exhaustion, and in the US, 21% leave their roles within 1 year. And there's some significant issues here to address. And then from the patient side as well, and I've taken some European stats, but you could also take this for North America, and it would be a similar picture. There is a falling patient satisfaction, and that is partly due to the fact that in healthcare, we are not necessarily providing the solutions that patients are seeing elsewhere, and there's higher expectations as well. So there is a bit, although the supply-demand mismatch is definitely contributing to this too. And then around the world, and we're seeing this in Europe, but it's true everywhere. Healthcare spend, we cannot continue to grow at the same speed it's been growing. So many markets, it's growing at 4%, whereas GDP is growing at 3%. That cannot continue to outstrip GDP. And in fact, there's a shift in spend at the moment with growing political uncertainties. So it may even have to fall below that. So if I were to sum up, though, on this section, I would say progress is undermined by three core challenges, because I think we know that digital and AI could really make a massive difference here and transform the way we deliver it. But it's quite challenging for policymakers and business leaders. They don't necessarily fully understand it or its implications or what they need to do to set a clear direction. And so they're making choices in a tactical way, which are not necessarily aligning with the strategic visions that we need. So that we're getting regulatory, financial barriers. We're not setting up the markets in the way that we need them to work to get to that sort of converging light. And then when we look beyond that, there's low confidence in AI within the public, particularly, but then also within the professional bodies as well on how to manage for that. It's hard to navigate a fragmented regulatory landscape. So, but what could it be? So I'll just spend a few moments to look at what a vision for tomorrow could be and what some of the elements are and how different nations are starting to move in that direction, at least. So 5 elements you could see for a future healthcare system that would address some of the issues that we've got there. So we should be going for 8 billion doctors. If we do this in the right way and enable individuals, then they all can have the doctor in their pocket with the digital front end to triage and support self-management and inform them on how to, with the appropriate agentic support. Also, they could direct them to novel pathways that are digitally enabled, which do not require the same amount of workforce input as we require today. There's already many of these in play. If you look at dermatology apps, if you look at some of the urgent care and pathways that have been put through, you can manage through this, as well as a lot of the simpler pathways around women's health, mental health, MSK. In addition, we can also start to be more proactive with this. If you start to underlie that with a data platform and proactively reach out, we can risk stratify and proactively manage people as well to support them on their journey. That will require a whole government approach to health for these things to start to really take bed in. As we know, something like 70 to 80% of some health conditions are due to broader determinants of health. So if we can address some of those social determinants and inform policies around diet, exercise, housing, working situations in a coordinated way, then we can start to move to shift the demand. And underpinning this, which there are a number of areas where we can get to operational excellence enabled by AI tools, enhancing productivity, which is where we actually are already starting to see some of the benefits. And then if we do that, I think this could lead to a sustainable approach to healthcare. And I like to think of around it like a harmonic sequence. And this is more visionary, but we can put data to support some of this. But if we can get to a health system that's predictive, participatory, preventative, and personalized, I think there could be a reduction by half in some of the generalist primary care activity by directing to self-care, so and/or digitally enhanced pathways. And we can see that if you look at in some nations like Platform 24 in Sweden, they have a 20% redirect to self-care, along with and then are adding digitally enhanced pathways, and from the analysis, 30 to 50% of their activity could shift. That would then in turn lead to a reduction in activity in hospitals up to a third. So many of the elements from the first part will be managed more earlier and more proactively, which will then reduce the activity burden, particularly around outpatients, A&E attendances, but also then that feeds through into some of the elective care pathways and some of the and then also into the non-elective pathways as well. Not all of that. Some of that would be fixed costs, but that could lead to a quarter reduction in resources that could then be redeployed to prevent and detect, which then would lead back into improved life expectancy. So this half to a third to a quarter to a fifth view of the world, I think, is interesting. Sonali, I will pause for a moment.
Yeah, so I'm curious to hear where these numbers come from, that a half reduction in this and one third. What is the data behind it, and where do these predictions come from? How robust are they?
So I can give you numbers from a number of markets where when people have done surveys on primary care activity and what could be redirected. And then I think particularly in primary care, we are starting to see it, as I mentioned, in some of the pathways. I mentioned Sweden, but there's a similar approach being taken in Portugal as well, which is having similar levels of benefit. When it goes through to a reduction in activity in hospitals, this is done from actually, if you look at surveys of ambulatory sensitive conditions that are treated in hospitals, you take also from some of the health insurance data from Europe, where they're looking across for some of the elective pathways for redirection for private care. So this is actually stitching together some of the data we're seeing. And I would say no healthcare system is yet doing this at scale, which is the issue. We're seeing it in points of light in different places where we could see that if this was done in a more coordinated way, it would start to deliver to this level. But tonight, this is not where we are yet, but this is looking to where we could be based on what we're already starting to see in the market if it was done in a more coordinated way.
Thank you.
So let me give you examples from 3 markets, and this is testing your flag knowledge here, but I'm going to take some work we've done with the Australian government recently, also some work I've done also in the UK that's fed into the 10-year health plan that's been recently published, and then an example from Finland as well with their DigiFinland, just to give a sense, and I'll put a little bit of structure around that as we go through. So if you start to look at AI use cases, and here's some ones that we're looking at in Australia most recently, and 12 cases that came up from some work that's already going on. Some which are bucketed into sort of episodic workflow that around diagnostic engines to support, and this can be supporting patients and doctors, to treatment recommendations, to triage and automation, care advisors as well, which can support patients to navigate their own health record as well, to agentic appointment booking and waitlist optimization. I'm sure there's many of those that you've already got in play or are thinking around, but they're relatively straightforward. Well, I think on those, they can actually make work life better for our professionals. They can, but individually, they do not transform the pathways and start to shift the demand curve significantly, but it can start to at least improve working conditions and give patients better support. When you start to connect these together is when you start to get into the ongoing health management, where you get around population health optimizers, where you start to do population screening, pulling together health information from a number of different sources to get to a unified view of the patient status, thinking about different scenarios as we model forward so you can forecast and plan appropriately, and then delivering personalized health coaching. And then the third bucket around clinical workflow support as well, which is preemptively identifying patients to redirect them to different pathways, and obviously ambient technology for AI clinical scribes. The way we think about it, though, is that we start to take those apart, is to start to think about what can we do now, which are some of the deploy activities at the top, adopting some simple tools to streamline. Secondly, reshaping. So as we start to think across important pathways, can we eliminate and redesign the pathway so it's not just digitizing the current pathway and all the steps, but actually designing a new pathway that does not require the same workforce effort, or can be delivered more rapidly or more to a higher quality. To completely reinventing the new care model, which I think is where you start to get a real shift as well. I think reshaping can get there, but inventing and what we see is some of the more to manage some of the biggest areas of workload, to treat disease in a completely different way. I'll go through pulling a couple of examples from different places. So we'll start with deploy. Now we've talked about that already, and some of the numbers here from Australia to give you from what they've been looking at, but around clinical scribes, care advisors, and agentic booking. And I think you'll all be aware of these, so I won't spend any time on these. When you start to think about reshape, this is things around, accessing urgent care, getting redirected to self-care or more timely primary care instead of turning up in the emergency room, matching patients to the acuity to their care settings. Or skin cancer risk, which I gave the example before. There's some great AI dermatology tools already out there for assessing moles, which have been well proven. We see this a lot in imaging technologies as well, in other areas as well. And then when you start to just to give you a sense on the urgent care pathway for that, in a little bit more detail, but you can start to add in new channels as well. So around self-care, pharmacy, and utilization of that better, GP consults and doing those online and remotely as well can be a much more efficient way of dealing with people. Appointments are often shorter. Urgent care clinics being utilized in a much better way, which can be staffed in a different way. So actually ED becomes a much less utilized route. As we know, when people turn up to ED, because of risk threshold assessments, people are much more likely to get admitted or be over-investigated as well. And then if we get into the invent, I'll just give some examples, 3 examples. So if you imagine for Amit here, got symptoms of low fever and cough. If there was an in-care app given, this is when you start to stitch it across a pathway. So you're pulling in together some of those things that I've already talked through. So AI companions and wearables data can inform that it's a likely viral infection requiring self-management. You could imagine an app auto-ordering viral point-of-care tests, which could be delivered. to confirm the viral infection, and you can then have an AI GP agent advising that antibiotics are not needed and getting to full recovery. All of that data getting auto-integrated into a centralized health system and utilized for infection tracking within the population. I think that and then that feeding into a digital twin powered dashboard, and those interventions being utilized to identify high risk areas and real time isolation alerts as necessary to contain any outbreaks. So all of that can then be put together into pathogenic genomic sequencing to track variants and informing vaccine development. And that would be an end-to-end pathway. All of those elements already exist. There's nothing new here, but we're just not putting it together in a sequenced way. From the other end of life, you give a vision for elderly people deteriorating in isolation, which can often happen. So, for example, if you have a current state, you can get an elderly person at home with a UTI, becoming increasingly confused, falls, breaks their hip, stuck at home, no one knows, until someone visits by chance and calls an ambulance, rush to an ED, take a while there, then have to go through hip replacement surgery, extended hospital stay to rehabilitate, and remains too frail, so ends up in a nursing home. Versus if we were actually having wearable home smart devices to flag low mobility, high pulse, could tell frequency in the toilet, you can identify that this person is likely has a urinary tract infection from the data. Auto alert notifies a community health worker who prioritizes to come to visit to a few days earlier than would have been planned, can take her antibiotics, get prescribed, track her medication adherence as well through the home monitoring system, and be updated as she improves. So within a few days, she can be back to full health. This can completely transform a pathway with technology that already exists and is being utilized, but not necessarily in such a coordinated way. And then I'll give you one example. Those two are from UK with some of the things that are being planned there, and this is a Finnish example which is already starting to be delivered for mental health. So if you think about mental health services and why it fails so often in the community, well, they think of the 40-40-30 rule. So there's a 40% of people. Only 40% of people seek care. 60% don't. So there's many people with social anxiety, depression, who just don't seek care and for months or even years, which can be debilitating. Of that 40%, only about 40% get evidence-based interventions. The 60% don't receive quality care on time. And then of that, only about 30% of those getting evidence-based interventions recover. So just focusing on that as part of the process cannot have a significant public health impact. However, when you start to talk about particularly some around the behavioral health issues, we worry about supply-induced demand. And that can be a concern. Well, if we were to address this, we wouldn't be able to manage the volume that comes through. So we don't want to manage the need. We just want to manage the current demand. But what happens if we were to have universal digital services that were not limited by our workforce, that could be automated? What happens if we did have appropriate primary care and mental health services that starts if people do get triaged through, that they can be addressed and that people get appropriately referred to the treatment? What effect would that have? We could then start to see something that would be much more coordinated across the whole spectrum, with digital self-help services coming in 24/7, therapy and intervention navigator tools that can navigate people through to the right treatment, e-learning systems for healthcare professionals to train up, because some of this treatment's relatively simple. It doesn't need highly qualified staff to deliver. And then appropriate outcome monitoring and registry to feedback around the loop. So that's the plan, and this was signed off 5 years ago in Finland as their plan. They have now and is now rolled out. So they're now monitoring to see the benefits of this as it comes through. Okay, everyone still with me? I'll push through into the next section if that works for everybody. So, sorry about that. I'm just messing up my slides here. There we go. Oh, sorry. That's fine. Let's do that. 6 shifts to drive change. So I've highlighted the 3 core challenges. Well, then how do we address this around AI health being challenging to policymakers? They're not really sure what to do. The technical choices are not aligning with strategic visions, and the low confidence in AI within this fragmented regulatory landscape. We have seen some examples that have started to pace through, but some of those are not necessarily going to scale. So how do we address that? Well, I think there are 6 shifts that need to overcome these challenges. So to go through that, so we need to get away from just being distracted by the bright, shiny objects to value-driven innovation models. And I think this requires, if you look in the US, estimates of something up to 30% of healthcare spending could be considered in wasteful. And yet, when we try to roll out AI projects, 80% of them do not reach scale. If we were to manage to get to a value-driven innovation model, there's a huge savings, estimated 150 billion for 2026, and over the next decade, that could amount to even higher operational costs. That if you take 30% as the waste, I think there's actually up to 40% that could be saved because we could reinvent, so beyond the current treatment paradigms. So to do that, that will take orchestration across a fragmented landscape to do that. And that requires not private, if it's just left to individual private companies coming in, the focus will be on short-term deploy interventions, and which is where a lot of it is. So if you look at FDA approvals for AI, over 70% of them are in imaging applications at the moment, which makes sense. Yeah, we've got a ton of data. It's actually relatively simple to invent to think about AI algorithms there, and there's starting to be a route to market now to get payback on that. Whereas we need some of the end-to-end approaches that I've just described, which will require coordination across more than one private company to make that happen. And that requires, digital health has to be a core shared priority. And I think estimates are that there's good ROI on this if you can invest at the right level in technologies for health. And if you think about public-private ecosystems, they already exist in other areas. DARPA is a great example of it for breakthrough technologies in national security of the last 60 years or so, with the internet, personalized computer, GPS, drones, even the COVID-19 vaccine had input. This is the type of approach we need to get to. So that requires not fighting on infrastructures, but actually moving to a future-proof data environment. If you think about electricity and water, we all have common pipes, common wires to transfer that. The banking system, banks are linked up, so you can a common approach that you can access your money in different banks. At the moment, that is not the case for many, our EPRs do not link well together. And many of these technologies are not linked well together. So this is a huge amount of money that's invested in infrastructure. And a huge amount of money is being spent for the future as well. However, what we actually need is effective infrastructure regulation to help direct that private investment towards higher value services, so that it's not just that actually interoperable. And that goes from waiting for rules and guidelines to proactively building trust and confidence as well. So, there's a lot of concern around AI, and actually, I was on a call this morning actually with governments from Denmark, Finland, UK, and Australia are talking around this with sort of examples of even simple things like AI scribes in the UK being delayed for over a year, the technology. Whereas in Australia, they've taken a more permissive approach to get things to market. So there are ways through, and I think US is better than many places in the world actually. But I think having these regulatory sandboxes to move things forward at pace is critical to build trust and confidence, and an approach to that which is stewards rather than for this technology to make sure that it delivers as the sort of philosophy for this with post-market surveillance. And that's particularly important for AI because these tools evolve and develop as the data gets better as they're in the market, so that we cannot be applying our simple med tech rules to these products. So that's going to require leaders with good intentions to actually transform organizations and systems. That means leaders need to actually be upskilled and understand what they're dealing with here as well, so that they actually can think about how to do this. And I think that is part of the journey we're on, to get to where we need to be. I think if we do that, then we can go from this dispersed data to a global corporation across networks. And I know majority of OECD countries, when this survey was done, had unstructured data for their health records. And actually, when you look at where AI clinical papers come from, US and China produce the majority of the papers at the moment, which is fine, but it does, and it probably works well up to a point. But when you look globally, that can lead to contribution to bias models as well, due to population demographic mixes. So there are many examples of health connected platforms that are emerging as people start to think about how we can start to stitch this data together to get to something more robust. So where does that leave us? I think when I look at national, local leaders, this shift, I think there is a pragmatic approach, is that we do actually need to focus on some short-term ROI to prove this, prioritizing some of the things around deploy and reshape, with an eye to invent. I think working with across an ecosystem as well, with shared goals and value through public-private enterprises, is going to be critical. I think this shift away from focus on competition on services to prioritize digital public infrastructure and digital public goods, blended financing strategies, and taking strategic tech decisions to deliver on that. And then I think on the final column around building transparency and trust, I think this movement toward a post-market surveillance and guidelines is critical for transforming how we do this, and making sure that people can see that it's still becoming more trustworthy over time, and keeping local control of the data within a global framework. Okay, that's the strategic part. So getting on to actually how that could be delivered and what it means from here, I thought it might be interesting to take a bit of a step back and think about it and from a cross-industry perspective as well, and what we see as a consulting firm working across many industries. Well, disruption's been happening for 30 years in digital, just to be clear. So, we've seen this evolve. So this isn't, and we're still on that journey. As we've seen it evolve, it's actually leads to disruption and profound change in the models of how these have been delivered. And some of those battles have been fought and lost, and some of them are still being fought. And when we think about it in healthcare, I think we're going to need something similarly disruptive for some of these changes to happen, and that will mean a shift in some of the big technology companies we see playing in there will change, and we'll see new entrants. I think some of the healthcare systems as well, and who are seen as leading healthcare systems, will shift as well, and with some getting left behind in this. And I think it's going to be an interesting space. How does that happen, and how can that happen, say, at Fred Hutch and other places? What would you need? Well, I think what innovation velocity, I think, is an interesting concept that we see across industries. And how do you accelerate those innovation cycles to go from where you are today to where you want to be in the future, and for you to be leading on some of those innovation areas? Sorry, wrong way. Well, healthcare is it's tricky. Healthcare is difficult, and that's why healthcare often is seen to be lagging behind on these digital disruption indices. This is one that BCG does, where we monitor across industries over time, and many of the healthcare elements just are down at the bottom end of the scale, missing opportunity to deliver impact. But this is because our pathways are much more complicated than automotive and technology. We have much more dispersion and fragmentation across our pathways as well, with many players on the pitch. It's not like Uber, which is a much more straightforward business model than some of the complex pathways we're delivering. So there's a reason for this, but that doesn't mean it's unsolvable. So, and when we look across, there is a lot, I'm sure it's the same there's many people using AI tools, and there is a big pull to use AI tools from clinicians as well, and many unregulated uses of AI tools as well, also already happening. I think we've noticed this over the last 18 months to 2 years, a real shift in the clinical community towards utilization of AI. However, making that scale and stick is not straightforward. And I would say when we look globally across companies, about 70% of companies fail on digital AI and transformation when you're actually trying to go in a more holistic way. The ones that do well, the 30%, have a rigorous focus on value, a tailored operating model, and a program to drive that executional certainty. So what does that require? Well, it means addressing your digital muscle, which I started to refer to earlier. So you've got to be able to attract and retain the best talent. You've got to be able to control some of the innovation antibodies, as I would call it. You will find, despite which means not holding on to what we have today. It's also about it's a more of a startup culture. So it's about how do we create those innovative processes to move fast, break things, rather than the slow, continuous improvement process cycles that we've had in the past. And then also making sure we can stick the journey as well. So digital activities don't become seen as a drain on resources, but are seen as a way to get to ROI over time. So this is our 10, 20, 70 approach to this, which, yes, you need the algorithms and the tech, but actually you probably have a lot of that. It's around the business processes and ways of working that's going to be the critical bit that you'll need to solve for to get there. So one of the ways thinking about this, and I don't know how you're set up at the moment, but innovation strategy teams are where we see this working well. Getting the right talent into that team, thinking about the processes that team will work for, and how to translate opportunity areas into investable business companies that can then putting the right governance around them so that those can be then scaled, and that they get the protection they need for their innovation efforts. I'm going to skip this one and go to this one because I think this is where is culture. It all boils down to culture. So we need to shift from a view where, and I think this is where it's really interesting within a hospital environment, because you will have two cultures. You will need the culture you have on the right. We need managers. We need continuous improvement, Six Sigma. We need to focus on profitability, safety, a clear way of delivering, which will be done in specialty silos, etc. But then we also need, for some of this digital disruption, we're going to need entrepreneurs that will move fast and break things, growth, risk, agility, working across functional teams. Now, this is where the challenge is. And I think the only way you can do this, you've already have the right, and that will become your dominant culture, which will stifle the left. For the left, you have to be setting up something different, and this is why I'm talking about setting up these innovation strategy teams within, and that's what is required for that to give a different culture to deliver the change that we're talking about. I'll finish on a quote from Machiavelli. He who innovates will have as his enemies all those who are well off under the existing order of things, and only lukewarm support in those who might be better off under the new. I do think it takes some visionaries in this to actually lead us through, and I think that you need to get the vision coming from senior places and organizations for this to happen. But it is starting to happen, and we are seeing it in many places, and so I am very positive about the future. Thank you.
Thank you, Ben. This was really cool. I have questions, but I'm gonna wait and see if others have questions first. Are you able to unmute yourself and ask your question, Michelle?
There's a lot of noise behind me, so I'm not sure. There's a bunch of banging. So can you hear it?
No, Teams
Oh,
is doing a great job of
oh,
filtering
it's
it out.
doing that. Okay, if it's filtering, I can barely hear myself. But I think, in working across different markets and more or less trying to use a global platform and not have to have one for every single market that's nuanced. That's obviously an enormous challenge for us. And when I was looking at your use cases, it sort of sparked this idea of, as an emerging, company, we're still a startup, but we kind of aren't. We're still in that position of it's always who pays. Is it the consumer? And when you get into places like Africa, is it the government? Is it, an NGO? But usually, no, it's still the patient. So how do you figure out what are the optimal use cases that would be, I think, a sound business case to where globally people recognize that is a value-driven scenario that helps advance a broader system. So we can hone in on mental health because we've got that. We could hone in on dental health. We could hone in on skin cancer, and we can hone in on any one of these things, or even populations. Is it 55 plus, or is it home care? There's all these different ways to carve it out. And I think when you've got a plug and play, how do you hone in and figure out like what's the optimal use case that everyone would they would get it and they see the value in it right out of the gate? Is there such a thing?
Yeah, it's a really interesting question, isn't it?
Sorry, I'm gonna just try and close that door. I was keeping an ear out, but I'm just, excuse me. I'm so sorry.
No, it's fine. I mean, my observation would be maybe a couple of observations, because I think that it's a big question actually. And when you look, if you're talking globally, I think observation one is, going back to where I started from, we have to have things that shift the demand curve over time. So that has to be number one, and it's shifting away from in-hospital care, which is just highly expensive. Now, the interesting thing in developing worlds is primary care is sometimes non-existent as well. So people are effectively in a self-care model anyway until they get to go to crisis.
Yeah. It's all in the home.
It is, yeah. So then, but if you are going to put something in place, there is something around the self-care model that enhances that then to some extent. So that sort of that first triage and support function in a couple of key pathways, which are probably where some of the most where you could actually have the biggest effect, is where I think, if you're looking from a health angle, would be the most interesting. So and there's quite a lot going on, and you will know it better than I, but around maternal care, for example, some of the and and you can pick out one or two pathways, and in cities as well, in developing world, we see that as well with cardiovascular care as well. So you can start to shift. I think that the question for you, though, as a model, who's going to pay is your key question. So is it going to be paid for, but it's going to be largely self-pay. So I think in India, where we see some of the most interesting innovations around that, is in that sort of self-pay model, or at the top end of the market. So because if you go, so in some of the larger cities, there's a higher penetration of health insurance there, so that they can then focus there as well. So you're going to have to be led by where you can get paid as well, aren't you? Which is the challenge.
Yeah, I think that's been part of the challenge, right? Is that when you're out looking to provide services to the masses and have just basic health equity, really basic access, it's actually looking to be potentially one of the most difficult markets to serve. It's actually, frankly, a lot easier to do a very premium concierge style home care solutions with cutting edge tech and have that paid for, and then a pay it forward model or something, for everybody else in the world. But that was, I think, unfortunately, I think you just are confirming some of the things that we've been bumping up against as we continually are looking at new markets and new solutions. And then I think there's also the bigger question of, like you said, like the wait lists in the UK, when you get into those types of situations, it's like, how do you empower the individual, but yet they don't want them to be too empowered. They still want them to come to the hospital and, be lifelong patients. So adding the value to the overall ecosystem that's also under, constant reductions and looking for ways to increase their revenues. And that's also a tricky one when you've got, so many different competing factors and regulations in place. So it's a little bit of a tightrope, I think, that everyone's trying to walk. It's like you want to bring as much to the home environment as possible and then have it bidirectional, so it's feeding back into the hospital and the ecosystem. But where's the line of permission, and what's most useful? Do you start with the patient first, or do you really look at the ecosystem and then try and be the glue between them? And we've sort of done a little bit of both, but it's a challenge.
Yeah, I recognize that. I think you're playing across a number of ecosystems as well, where the rules are quite different, from a high income setting to the low income setting as well.
US to Africa to it's like looking at it from a lot of different perspectives. So well, I appreciate the presentation so much. I don't want to hog the microphone. I'll back out to let others talk, but I'm sure I could talk to you for a few hours on this. So thank you. Appreciate the
let's stay in
insights.
touch.
Yes, please.
Yes, so who pays for it is one angle here, and also who bears the liability, right? Like our last month's speaker was from a legal angle, so we heard about the legal aspects of this. So if something does go wrong, so even though overall the AI systems may potentially be even better than, because there are human errors, but the pathway, the liability is clear and there is existing systems there. But in case of an AI, like it's not clear yet because of that regulatory lag, right? So, so in the success stories that you have seen, Ben, like how do people navigate that? How do the leaders feel confident in implementing these solutions in sort of a regulatory vacuum?
So maybe three observations. I don't have the whole solution, but one is for front end access and triage. I think if you're not shutting other channels, the issue is around channel shift here. We're giving people a channel which is faster and more responsive and more personalized, but we're not shutting the other channel. So this is like people access, and we can say, yeah, you should seek help, and here's one option, but people can still go to see their GP or turn up at A&E. So they carry the risk. Then they're making a choice, but we're just giving them an option. And I think then you end up in a class 1 medical device area territory, and I think so. That's one piece. I think the second piece is obviously with some of the AI in imaging and all the rest. There's humans in the loop still, and you're getting it with I think that's where some of the technology for AI scribes is running. It's still should be human in the loop to sign them off. It will wrap, and so for typically on AI scribes, some of that is automatically shared with the patient as well, so they get visibility, and actually it's more transparency than they had before. So I think that human in the loop piece is critical too. I think where we want to go is for greater automation. So, if you like Hippocratic AI, for example, which is rapidly growing in the US. I don't know if you've come across that, which is like an AI nurse, basically, that calls you up. That is and is great because it's infinitely patient. Will call up people to get them to take their blood pressures and do things that are relatively low risk at the moment, but is already expanding to other use cases, which are starting to tread into new territory because effectively they are giving advice and there is no human in the loop. But they're getting stronger and stronger because every conversation adds to the database. I think that we are getting to a point where this non-inferiority, as long as it's non-inferior, and we can prove that with robust data, then I think and this is the trust element, which I talked about. I think there is a shift, there is a paradigm shift happening already, and we're seeing it in sort of some males in mental health would almost rather speak to an AI than a human, you know, and then in these situations where we're going to see it, actually people would prefer it because they trust it more. So I think we're not there yet, but we're getting to a tipping point in some places on that.
So we're almost at the end of the time. Is there any one quick question or something before we say goodbye? Okay, thank you very much, Ben. This was really good. I was really looking forward to your talk, and you covered a lot of different examples from different places, and we have it recorded for others who could not join us today. Thank you again very much, and I'll follow up with you.
No problem.
Goodbye.
Nice to meet you all. Thank you. Have a good day.
Thank you.
Thanks. Bye, everybody.
Thanks, Sonali.
Thanks.